persistence and course. In contrast to major depression, anxiety disorders are often chronic over many years with relatively low remission but more variable rates of relapse after complete recovery. The Harvard-Brown Anxiety Disorder Research Program, HARP, an 8-year prospective study found that only 1/3 or 1/2 of patients with social phobia, GAD, or panic disorder achieved full remission. The Zurich cohort study found that nearly 50% of individuals with an initial anxiety disorder later developed depression alone or depression comorbid with anxiety at a 15-year follow-up. A Dutch longitudinal study of 3,107 older individuals found that 23% of subjects with an initial DSM-3 anxiety disorder continued to meet criteria 6 years later, whereas another 47% suffered from subclinical anxiety. It is evident the anxiety disorders persist for many years when not treated. Given that the majority of these disorders have their onset in childhood and adolescence, the chronic nature of anxiety is a significant component of its overall disease burden. Biological aspects of anxiety. Anxiety is multifaceted, involving diverse elements of the physiological, cognitive, behavioral, and affective domains of human function. The automatic physiological responses that typically occur in the presence of threat or danger are considered defensive responses. These responses, seen in the fear-eliciting context of both animals and humans, involve autonomic results that prepares the organism to deal with danger by fleeing or by directly confronting the danger, a process known as the fight or flight response. The behavioral features primarily involve escape or avoidance as well as safety-seeking responses. The cognitive variables provide the meaningful interpretation of our internal state as that of anxiety. Finally, the affective domain is derived from cognitive and physiological activation and constitutes the subjective experience of feeling anxious. In the following sections, we briefly discuss the physiological, behavioral, and emotional aspects of anxiety. Many of the symptoms of anxiety are physiological in nature, reflecting activation of the sympathetic SNS and parasympathetic PNS nervous systems. Activation of the SNS is the most prominent physiological response in anxiety, and it leads to hyperarousal symptoms such as constriction of the peripheral blood vessels, increased strength of skeletal muscles, increased heart rate and forced contraction, dilation of the lungs to increase oxygen supply, dilation of the pupils for possible improved vision, cessation of digestive activity, increase of basal metabolism, and increased secretion of epinephrine and norepinephrine from the adrenal medulla. All of these peripheral physiological responses are associated with arousal but cause various perceptual symptoms such as trembling, shaking, hot and cold spells, heart palpitations, dry mouth, sweating, shortness of breath, chest pain or pressure, and muscle tension. The role of PNS excitation, which causes a conservation of certain physiological responses, has not been as well researched in anxiety. The PNS is involved in symptoms like tonic immobility, drop in blood pressure, and fainting, which are type of conversation withdrawal response strategy. The effects of PNS stimulation include decreased heart rate and force of contraction, contracted pupils, relaxed abdominal muscles, and constriction of the lungs. Moreover, research on heart rate variability in panic attacks indicates that the cardiovascular activity associated with anxiety should not be seen simply in terms of excessive SNS activation, but also reduced compensatory PNS excitation. Thus, the PNS probably plays a greater role in anxiety than previously considered. Barlow concluded that one of the most robust and enduring findings in the past 50 years of psychophysiological research is that chronically anxious individuals exhibit a persistently elevated autonomic arousal level, often in the absence of an anxiety-producing situation. For example, Cuthbert et al. Reported significantly elevated heart rate-based levels for panic and specific phobias, but not social phobia or post-traumatic stress disorder (PTSD) groups. Other researchers, however, have linked anxiety or neuroticism to excess autonomic lability and reactivity rather than to enduring tonic levels of activation. Krask proposed that heightened cardiovascular reactivity might be a predisposing factor for panic disorder, such that the tendency to experience intense and acute autonomic activation could increase the silence and therefore threat attributed to bodily sensations. Empirical support for autonomic differences between anxious and non-anxious controls in response to stressful or threatening stimuli has not been consistently obtained across studies. Friedman and Thayer also noted that psychophysiological findings of reduced heart rate and electrodermal variability challenge the view that anxiety is characterized by excessive autonomic lability and reactivity. Nevertheless, anxious individuals do show a slower decline in their physiological response to stressors, but this is probably due to their higher initial baseline arousal level. In addition, Lang and colleagues found greater physiological arousal to fear-relevant imagery in snake-phobic individuals, but reactivity was less evident in those with panic. Together, these results suggest that heightened physiological reactivity to fear stimuli may be greatest in specific phobic conditions but less evident in other anxiety states like panic disorder or PTSD. However, a heightened basal arousal level and slower habituation rate might be seen more consistently across various anxiety disorders, thereby providing the physiological basis for chronically anxious individuals to misinterpret their persistent state of hyperarousal as evidence of an anticipated threat or danger. Recent psychophilosophical research suggests that individuals with chronic anxiety exhibit diminished autonomic flexibility in response to stressors. This is characterized by a weak but sustained response to stressors, indicating a poor habitation trajectory. In a study of heart rate reactivity under baseline relaxation and worry conditions, Thayer, Friedman, and Berkovich found that individuals with GAD or those actively engaged in worry had lower cardiac vagal control, which supports the view that GAD is characterized by autonomic inflexibility. In sum, it would appear that important psychophysiological features of anxiety, such as elevated basal arousal level, slower habituation, and diminished autonomic flexibility, might contribute to the misinterpretation of threat that is the core cognitive feature of anxiety. However, a different physiological response pattern may distinguish phobia, panic disorder, and GAD, which prevents generalizing research findings across the anxiety disorder. Furthermore, it is unclear whether the anxiety state is primarily an excess of SNS activation and a withdrawal of vagal activity, or if SNS activity is depressed and PNS activity remains normal under the conditions of daily living. Genetic factors. There is considerable empirical evidence that anxiety runs in families. In a meta-analysis of family and twin studies for panic disorder, GAD, phobias, and OCD, Hetema, Nela, and Kendler concluded there is significant familial aggregation for all four disorders, with the strongest evidence for panic disorder. Across all disorders, estimates of heritability range from 30 to 40%, leaving the largest proportion of the variance due to individual environmental factors. Even the symptomatic level, heritability accounts for only 27% of the variability by predisposing individuals to general distress, with environmental factors determining the development of specific anxiety or depressive symptoms. Barlow raised the possibility that a separate genetic transmission might be evident for anxiety and panic. In a structural equation modeling of diagnostic data collected on a large female twin sample, Kendler et al. Found separate genetic risk factors for major depression and GAD on the one hand, and for acute, short-lived anxiety like phobias and panic on the other. An earlier study also found a common genetic diathesis for major depression and GAD with disorder specificity determined by exposure to different life events. There is less evidence that individuals inherit specific anxiety disorders and stronger empirical support for inheritance of a general vulnerability to develop an anxiety disorder. This non-specific vulnerability for anxiety could be neuroticism, high-trait anxiety, negative affectivity, or what Barrow, Allen, and Coates called a negative affect syndrome. Vulnerable individuals might show a stronger or at least more sustained emotional response to aversive or stressful situations. However, environmental and cognitive factors would interact with this genetic predisposition to determine which of the specific anxiety disorders is experienced by a particular individual.